Okay, it's now live in on YouTube, right? Achha, recording will start. I'll start the recording.
Dada, we are live.
Yeah. I just see. So I think so. There is a problem of display of slide. Yeah, correct. Is there any technical problem we have? Yeah.
आपके द्वारा डायल किया गया नंबर
Nanda Kumarji, is there any problem? Have you spoken to sir regarding?
Yeah, he said that we can start by 7.
Take it. Not an issue.
Waiting for more logins to come.
Okay.
गुड इवनिंग दादा.
गुड इवनिंग. तो पहुंच गया?
हाँ पहुंच गया. गुड इवनिंग नंद कुमार जी.
Good evening, thank Santosh ji. Good evening.
हाँ good evening Srikanth and everyone.
Srikanth left. He has started the YouTube live.
Okay. Dada, I'm there. I am connecting with my currently with mobile is there. I'm connecting with laptop. Okay, if any glitch, please. I'm there.
Have you reached?
Yes, just reached. That's why I log in with my mobile.
Okay, not an issue.
I'm logging with laptop.
Okay, sir. Good evening. Could you hear me, sir? Yeah. Your slide is visible, sir. I can see your slide. Sir, could you hear me?
Hello. हाँ करूँगा. हाँ करूँगा ना.
Sir, you just unmute and because you are mute.
Yeah. Change, sir. Sir said that we can start now.
We can start now, sir. Sir, could you unmute yourself?
Akshay sir, आप unmute करता कर जरा.
Sorry, sir.
Sir, could you unmute yourself and if you stop sharing, then I can share some slides of my because I understand. Sir, we'll be having an opening.
Good evening, everyone.
Good evening, sir. Good evening. Sir, the event flow will be
Hello.
that we will be having an opening. Mr. Nand Kumar will be doing a opening for you. Then he. Hello. Hello.
हाँ सर, काय बोलताय?
Hello.
हाँ काय
Hello.
विचारताय?
Hello.
Sir, Akshay sir, can you hear us?
Could you hear me, sir?
Hello.
Yes, sir. Could you hear me? Could you hear me, sir? Could you hear me? नंदू कुमार जी एक बार देखिए ना, बात कीजिए ना सर से, बोलिए जो सर को बोलिए कि ईयरफोन यूज करने के लिए, इफ यू कुड नॉट हियर अस. My slides are visible.
Yes sir.
Yes, Dada.
Yes.
Hello. Hello.
Yes, visible. हाँ सर,
Hello.
ओपन करतो आम्ही आता. तुम्हाला आवाज येत नसेल तर तुम्ही हेडफोन वापरता.
Exactly. Sir,
माझा आवाज येत नाही का?
तुमचा येतोय.
No.
तुमचा येतोय आम्हाला.
आता यायला लागला मला. आता आवाज यायला.
ओके आता क्लियर आहे.
You cannot. Yeah.
Yes sir.
Sir, could you hear me also? मेरा आवाज आ रहा है आपको?
या आ रहा है.
आ रहा है ना? ठीक है. सर हम लोग ओपनिंग से शुरू करेंगे. We start an opening.
Yes.
Then that Nand Kumar ji will hand over the session to you, right? After
Okay.
that, your session will be over. There could be that question answer, and lastly there will be the closing.
Yes.
Right. So, sir, I just tell you that initial you just go a little bit slow because the doctors are joining. So then you can take your
we'll do that.
right? Okay. So we can start, right? I just share the PPT. Okay, just one. Yes. My PPT is visible.
Yes.
Okay.
Yes.
So Nanda Kumar ji, could you start that?
Yes, sure. Yeah. Good evening, doctors. I am on behalf of Zydus welcome you in IBS Gurukul. And as you know, IBS is increasing rapidly, and you would agree that one size fits all approach is not applicable for IBS, and therefore we have organized IBS Gurukul. It is our pleasure to have Dr. Akshay Deshpande as a speaker of today's IBS Gurukul. Today's topic is recent update in IBS management. Dr. Akshay Deshpande is consultant gastroenterologist at Antarang. He performed over 8,000 OGD, 4,000 colonoscopies, and 2,000 therapeutic endoscopies. Dr. Akshay Deshpande was trained in therapeutic procedures, including ARCP and EUS. Moreover, his special interest in GI motility and IBS. We believe that this IBS Gurukul will be useful in your day-to-day practice. During this IBS Gurukul, you can post your questions in the chat box. And now I request Dr. Akshay Deshpande to start today's IBS Gurukul. Over to you, sir.
Yeah, thank you.
Yes, sir. Over to you, sir. Yeah.
I think you need.
Yes, sir. Tell me.
Yes. Yeah, good evening. Thank you, Nandkumar, for a warm introduction. Thank you, everyone, for joining this session. So let's begin the session. Today, we are going to discuss regarding irritable bowel syndrome. How do we diagnose it? What is the definition of IBS, and when do we, based on what criteria we diagnose it? What are the types? How do we, what is the pathogenesis or pathophysiology? And we'll later on discuss regarding the evidence-based management. So to start with introduction, IBS is the most common form of functional bowel disorder, and it is characterized by recurrent abdominal pain, which is associated with change in defecation or change in bowel habits. Its prevalence ranges from about 3 to 25%, and in most studies, the prevalence was about nearly 10%. IBS prevalence in Asian countries varies between 5 to 10%, based on whatever the gender or ethnicity. In India, multiple studies have shown the prevalence of nearly about 4.5%, 4.2%, but probably this is an older data, and the recent data may be of much higher prevalence rate. IBS is slightly more common in younger age group, which is less than 45 years of age, and prevalence is higher in women as compared to men. So, diagnostic criteria of IBS is mainly based on ROM4, which is ROM is an organization of functional bowel disorders, and it has brought out many criteria for many functional bowel diseases, and IBS is one of the functional bowel disease. And the criteria to diagnose IBS is according to this. It states that whenever a patient is having recurrent abdominal pain, and on an average, this pain is present for at least 1 day in a week, and this pain lasts for nearly 3 months. Along with this, there should be two associated symptoms. That is, this pain has to be related with defecation, and it is associated with either change in frequency of stools, or it is associated with change in form of stools. If the above criteria is met and it lasts for nearly about 3 months with symptoms onset in which was about nearly 6 months prior to the diagnosis, then the patient fits into the diagnostic criteria of IBS. So once we diagnose a patient with IBS, there are multiple sub classifications which are defined in IBS. Among this, I would like initially, this is the figure A, which is a Bristol classification of classifies stools into 7 types. Type 1 and 2 is hard and pellet-like stools with a hard lumps, or it can be a nut type. It can be, and type 6 and 7 is a loose stools basically. It can be fluffy or it can be watery. In between, that is type 3 to type 5, it is a semi-solid kind of stool, which is sausage type with cracks, or a sausage with snake-like appearance, or with the soft blobs. Once you define a stool based on a Bristol classification, then you tend to sub-classify it. There are mainly 4 sub-classifications. One is IBS-C, that is IBS constipation variant. IBS-M, that is IBS mixed type. IBS-D, which is a diarrheal variant. IBS-U is an unclassified variant. So how do I fit a patient in a subcategory of IBS? IBS-D, you call it when more than 25% of this stool passed by a patient is of type 6 or type 7 type, and less than 25% of the stool is about type 1 or type 2 type. Then this patient fits into a criteria subtype of IBS-D. In case of IBS-D, predominant stool type is type 1 and type 2, that is mainly hard stool, and it is more than 25% of the times. And it is on less than 25% of the time patient passes type 6 or type 7 type of stools. In IBS mixed type, it is a 25% of type 1 and 2 and 25% of type 6 and 7. So it's a mixed type of disease. If any of the patient does not fit into any of these three subtypes, then you put that subcategory, that patient into a IBS sub unclassified variant. So among the subtypes, the commonest form, it depends on mainly on the locality whether it's a rural or an urban population. But overall, IBS diarrheal form is slightly more predominant than IBS constipation form, and their mixed form is also equally contributes equally nearly about 25 to 30% of the patients with IBS. So the next most important thing in IBS is to understand the pathogenesis of this disease. As you can see, there are multiple factors which contribute to IBS, and this pathophysiology is multifactorial. The first and foremost, one of the cause is the genetic predisposition. On genetic analysis, it was found that many patients with IBS have sodium or a chloride or a serotonin channel problem, which causes, which leads, which predisposes them for having an irritable bowel syndrome. The next one is the environmental pollution. In this category, mainly it is the toxins which we consume or preservatives which are added in the food or allergens in the food, which cause inflammation in the intestine, and they also irritate the intestinal epithelial cells, thereby initiating a inflammatory process in the epithelial lining of the gut mucosa. The next one is the changes in gut-brain axis. This I'll discuss it in my next slides, and which is the main backbone of the backbone of the pathogenesis in IBS. Changes in motility of the intestine and immune dysregulation goes hand in hand. By this, what I meant to say is, when there was a large prospect trial wherein the biopsies of the intestine were taken from multiple patients with IBS, and these biopsies on histopathological examination showed that there was large amount of inflammatory cells in the mucosa. Along with that, there was a high level of histamine and other pain-producing neurotransmitters in the bowel, in the mucosa. So, whenever there is an inflammatory process, along with increased pain-sensitive neurotransmitters in the intestine, that leads to increased motility of the intestine, causing changes in motility of the intestine. And changes in visceral perception, as I told you, there are toxins, intestinal infections, added food preservative or allergens. All these irritate the intestinal mucosa, thereby leading to an inflammatory, initiating an inflammatory process and causing increased release of pain-sensitive neurotransmitters, which in turn initiate a neurotransmission process, causing increase in visceral perception as well as change in motility of the intestine. Alteration of the gut microbiota is another pathophysiological process which happens in IBS. Normally, our intestine has bacteria, it has got fungi in it, and there is a normal count of the bacteria of each type which is present in the intestine to carry out whatever the routine digestion process of a human being. But whenever this bacterial what can I say, bacterial levels dysregulate, that leads to a disease in a human being. The same happens with IBS. Normally in gut, there are something called as bacterioids, there are something called as firmicutes, there are coliform organisms. These three are present in equal number of quantities. Whenever this numbers variate or there is increase in one form of the bacteria as compared others, then there is initiation of an inflammatory process that leads to alteration in gut microbiota, causing an inflammatory bowel disease. The next causative factor is psychological process. Nearly about 50% of patients with IBS have got one or other form of psychological disorder. And the most common association is anxiety disorder followed by depression. There can be an associated fibromyalgia as well. So whenever psychological symptoms are present, there are multiple somatoform symptoms which also start like aches and pains in joints, in muscles, backaches, headaches, which are also very commonly associated with IBS. These symptoms are together clubbed as globus symptoms in IBS. If globus symptoms are present in a patient with IBS, then most likely that such patient is going to have an underlying psychological problem. So this was in brief outline about pathogenesis or pathophysiology of IBS. So as I told you, I'm going to discuss the gut-brain axis, which is mainly the backbone in pathophysiology of IBS. This is one of the theoretic. This image is from an EGM, which is mainly states about a study which was carried out in mice, and a theoretical model was established based on study in the mice. So this is the first part of the diagram wherein which shows the healthy intestinal bowel. You can see this is the lumen of the intestine, this is the epithelial lining of the intestine, and this is the submucosa. So here what has happened, this is a normal gut flora where pH is maintained and both bacteria as well as epithelial cells are working in symbiotic environment and the digestion process is going on normally. You can go into the next slide over here, a part of next slide, where you can see that these epithelial linings are not tightly attached. You can see there is a despacing. The villi are not properly aligned, and there is an inflammatory process going on into the lumen. This process is mainly caused by chronic inflammation like an ischemic disease. It can be a medication or a trauma. It can be an acute infection of bacterial, viral, or parasitic, bile salt malabsorption, alteration in the ionic channels like sodium, chloride, guanine cyclase, or as I told you, food allergens can also cause such initiate an inflammatory process. Whenever such inflammatory activity sets in the lumen of the patient, it leads to fermentation of food products, which causes release of gases, which in turn cause distension of the intestine and altering the colonic mobility and thereby causing symptoms of bloating and discharge. So next part I'll just discuss you. As I told you, these are epithelial cells wherein the tissue adhesions have gone and this epithelial lining has become leaky. That is, there is free flow of ions as well as inflammatory mediators across the epithelial cells. So when such a thing happens, there are toxins which come into the submucosal part and they initiate an inflammatory process. Once an inflammatory process sets in, there is release of large number of mast cells, dendritic cells, which reach this place, and these cells release neurotransmitters like histamine, tryptase, serotonin, TNF alpha, proteases, and interleukins. These inflammatory mediators, as well as neurotransmitters, cause change in enteric nervous system, causing increase in neuromuscular function, upstream signaling of the afferent neurons, and this signals in turn through the spinal cord. It reaches to the brain, and thereby causing modulation of neuromodulation of the pain. So this slide is an extension of gut-brain axis. I have described you what happens at the intestinal level. So basically what happens is there is an inflammatory process which causes release of increased inflammatory mediators, neurotransmitters. These transmitters in turn initiate a process in the neurons, causing something called as neuronal plasticity. That is, what by plasticity, what means is, even though in absence of inflammation in the intestine, there is a stimulation which is going on to the spinal cord. From the spinal cord, it reaches in the brain, basal ganglia, hypothalamus, thalamus, causing increased release of stress hormone, that is cortisol releasing factor. Once stress hormones are released in large amount, which in turn again causes increased release of pro-inflammatory cytokines, and also thereby it increases GI motility. So this forms a cascade of reaction, and it is a continuous cycle which goes on unless and until you inhibit or interrupt this cycle at one point or the other, this disease is not going to come under control. So this was about pathophysiology, and brain axis is dysregulated, or it is not functioning in a proper way in a patient with IBS. That leads to a repeated process or frequent relapses, which happens in a patient with irritable bowel syndrome. So as we have described when to diagnose a patient with IBS based on the criteria. There are some red flag symptoms which physician has to keep in mind before diagnosing a patient with IBS. Suppose a patient has come with pain abdomen and altered bowel habits, and he fits into the diagnosis of IBS. Along with that, you need to ask patient all these symptoms, and if these symptoms are not present, then only he is going to fit into the diagnosis of IBS. These symptoms are like, if the age is more than 50 years and there is recent change in bowel habits, if there is a family history of GI malignancy and it has been detected at the younger age, if there is a presence of anemia, PR bleed, stool occult blood being positive, if the symptoms are present in the night, there is unintentional weight loss or a significant loss of appetite, palpable lymphadenopathy, presence of fever, or presence of ascites. All these things, symptoms, if these are present, then such patient cannot be fit in such patient cannot fit into the diagnosis of IBS. This is one of the flow chart which are taken from API. As I told you, this is the diagnostic criteria. If the alarm symptoms or red flag symptoms are not present, then the patient probably has IBS. Such patients should be evaluated with basic tests like CBC, a stool routine, and a C-reactive protein. If all these things are normal, then patient definitely has got IBS, and you initiate the treatment accordingly. If the patient is having a refractory symptoms or he relapses multiple times, then you refer the patient to gastroenterologist for further evaluation. But if the patient has any of the red flag symptoms, then you definitely have to refer the patient to gastroenterologist for further evaluation. So, what are the differential diagnosis of patient who has got symptoms of IBS? There might be an associated infection, chronic infection like hernia. There can be a parasitic infection. Along with that, other differential is inflammatory bowel disease. In our day-to-day practice, whenever we both the symptoms of IBD and IBS closely match together, but the way to differentiate them is as I told you, red flag symptoms are one of the ways to differentiate. And if there is suspicion, such patient need to undergo an upper GI scopy or a colonoscopy for confirmation of IBD. Celiac disease is one disease where there is gluten sensitivity, or it is a sensitivity to food products which contain gluten, which causes symptoms like IBS. There might be a bloating, it can cause diarrhea as well. The main the way to investigate is you do a serology for celiac disease, that is IgA tissue transglutaminase, or you can do an IgG anti-endomycin antibody. If these are positive, then you do an upper GI scopy and take uh, biopsy from second part of duodenum. If duodenal mucosa shows villus atrophy, that confirms the diagnosis of celiac disease. In the recent days, eosinophilic GI disorders are increasingly being detected, and the change and the symptoms of this as well as IBS are very similar. And the only way to diagnose eosinophilic GI disorders is you take a biopsy from either esophagus, stomach, or in the ileum. And if it shows significant number of eosinophils in that part of the mucosa, that clinches the diagnosis of eosinophilic GI disorder. And the management is totally different from what we treat IBS. Eosinophilic GI disorders mainly are treated with short-term course of steroids and other immunosuppressive medicines. So these are the differentials whenever a patient comes with symptoms of IBS. So once you diagnose a patient with IBS, how do I assess the severity of disease? Severity of the disease is assessed by various questionnaires like this: functional bowel disease severity index, IBS symptom severity index, health-related quality of life index, hospital anxiety and depression scale, IBS 36. All these are questionnaires which are available on internet, and anytime you can log in and check whether what is the severity of patient. If the patient has got very severe form of disease, then most likely that he is going to need a long-term treatment and a holistic approach. That is what I can see. Along with this, I would also like to highlight there are these two questionnaires, that is health-related quality of life, hospital anxiety, depression scale. Patient with IBS have severe morbidity, I can say, and according to an US data, nearly 75 patients lose nearly about 75 days in an year. That is 75 days out of 365 days. They lose their pay if they are attending a job. They quit their school because of this problem, and it significantly affects their income aspects as well, social life, as well as financially. It leads to a lot of burden. So treating a patient of IBS is very important so that he is relieved of these problems and he can get back to his life normal. So this was all about the diagnostic criteria, pathogenesis, pathophysiology, and what are the red flag signs. So next is, once you diagnose a patient with IBS, how do I treat such patients? Treatment is basically multimodal approach, and treatment targets are at multiple levels. As I told you, based on the gut-brain axis. So let us see what is the treatment aspects. The first one is target is at the brain, at the level of this central nervous system. Here there is mainly you need to control the stress aspects as well as initiate central modulation of pain, so that the stress symptoms are controlled, release of cortisol releasing factor is controlled, and the cortisol stress hormones are also controlled. This is the first target. The second target is at the spinal cord, that is causing modulation of the pain with the help of either a GABAergic problem or a benzodiazepine or tricyclic antidepressants. Then at the intestinal level, you treat at multiple aspects again. One is you control the infection, restore the gut microbiome, control visceral hypersensitivity, and also regulate the intestinal motility. So our management is going to focus on all these three targets, as well as some other dietary as well as lifestyle modifications. So initial start is with the diet as well as lifestyle changes. Among the diet, based on the previous studies as well as guidelines, IBS patient need to be on a low fat FODMAP diet. The FODMAP stands for fermentable oligomonosaccharides and polyols. I'll just describe this in my next chart. And this low FODMAP diet usually helps to control global symptoms with IBS. The next one recommendation is regarding soluble fibers. Patient with IBS and constipation need to have taken a high amount of soluble fiber and reduce the amount of insoluble fibers. Gluten restriction in a patient with IBS, there is insufficient data regarding this aspect. But however, a patient with celiac disease can also have irritable bowel syndrome. Close clinical evaluation and ruling out celiac disease is very essential whenever symptoms of intolerance to gluten are present in a patient with IBS. Lactose intolerance, it is said that nearly about 10 to 15% of patients with IBS have got lactose intolerance, and one of the reason for that is could be because of small intestinal bacterial overgrowth, or they might be having an adult onset lactose intolerance, and the diagnosis is mainly based on lactose breath test. And if the presence of hydrogen amount is higher in a lactose breath test, that clinches the diagnosis of it. And the main treatment is to limit amount of milk or milk product to less than 250 milligrams. Or in spite of doing this, if the patient is symptomatic, then probably the patient has to completely reduce the lactose diet. So all these dietary changes needs to be undertaken, and these things help to reduce intestinal motility, control intestinal permeability, and also restore the normal gut microbiome. Low FODMAP diets, as I told you, fermentable monosaccharides and polyols. These things are present in our day-to-day diet, and they contribute nearly about 70 to 80% of the diet whatever we are consuming. You can see that these are the list of things which have got FODMAPs, and it is not possible for us to eliminate all these things. So if that is the case, how do I what is the diet advice I give to my patient? Basically, it is mainly an individual based approach you need to make in a patient for a dietary plan in a patient with IBS. And individualization of diet is very important. Ask the patient to look for things for which he is intolerant and try to avoid or reduce the quantity of such products. And then if in spite of such dietary restriction, if the patient continues to have a problem with bloating, or it can be an abdominal distension, or it can be increased phosphorus, then you need check for gluten insensitivity. Also look for a lactose intolerance in such patient. And the other thing is you need also look for a small intestinal bacterial overgrowth syndrome, which can be present in a patient with IBS. So I was discussing regarding soluble fibers. High fiber diet is one of the recommendation for patient with IBS constipatory variant. And the reason for recommending soluble fiber diet is that these fibers are not fermentable by gut microbiota. Hence, if they are not fermented, there is no release of excess gas in the intestine. If there is reduced release of gas, then there is reduced colonic distension. So along with this, soluble fibers also help to retain water content. they reduce the colonic transit time, and also they reduce the contact time between the pathogen as well as intestinal mucosa, thereby helping to control the symptoms of IBS. Soluble fibers are mainly present in psyllium, oat bran, barley, and beans predominantly. Along with this, they are also present in nuts, seeds, lentils, fruits, basically citrus fruits, as well as apples, strawberry, and some other vegetables. So basically, increase in soluble fibers and reducing the amount of insoluble fibers. That is what we recommend. So I told you regarding the dietary modifications which patient needs to make. What are the lifestyle changes that the patient needs to make? It's basically initiating a healthy lifestyle. You need to initiate exercise. It can be in the form of yoga. It can be in the form of meditation. All these things help to regulate our stress hormones, and thereby these things act mainly at the level of thalamus, and controlling the stress hormones also helps to control symptoms of IBS indirectly. And exercises as well as yoga increases the reduces the colonic transit time and increases the motility, colonic motility. So, coming to the medication aspect, which we are going to discuss now, and the next thing is how do we restore the gut microbiota? One of the way controlling the or restoring the gut microbiota is treating with antibiotics. Antibiotics are available in various forms, and one of the antibiotics which we use commonly is rifaximin. It is mainly a non-absorbable antibiotic, and, uh, and and it is not absorbed from the gut into the blood, into the blood vessels. So chances of adverse reactions are very minimal, and one the usual recommended dose is 550 mg BD for a period of 2 weeks. With this, the pathogenic colonic microbiota gets reduced, and restoration of the normal colonic mucosa, colonic or intestinal mucosa happens over next few periods, and which in turn helps to control the inflammatory process which was happening in the intestinal lumen. Also, another recommendation for rifaximin is, as I told you, small intestinal bacterial overgrowth. Even rifaximin also helps to control the symptoms of SIBO. So once the patient is treated with rifaximin, there is significant reduction in pain, as well as it increases the consistency. There are numerous studies which are available for a role of rifaximin, and it is mainly recommended in a patient with IBS diarrheal variant. Uh, and even there are many guidelines which recommend rifaximin for IBS. So after rifaximin, is there any role of pre or probiotics in IBS? So there have been multiple studies which have checked role of probiotics in IBS, but the problem is that there is no standardized endpoints, and the number of the patient in the study was less, or they most of the studies have used single species as a trial, so there is not enough data to arrive at conclusion at present. So the proposed mechanism of using probiotic is basically restoring the healthy gut microbiota, and most of the studies have shown that use of multiple species over single species whenever it comes to a probiotic. And at presently, there is no recommendation by ACG guideline, which was recently published in 2021. But there are many Asian guidelines which do recommend probiotics for treatment of IBS. But what we use routinely is use probiotic in a patient with post-infectious IBS, and which definitely shows significant improvement once we treat them with a probiotic. So basically, larger trials are needed when it comes to probiotic in case of IBS. The next one is, how do I manage pain in case of IBS in a patient with IBS? There are multiple medicines as well as oils which are recommended. One of that is peppermint oil. It is basically derived from N-menthol, and it works by blocking calcium channels and thereby causing smooth muscle relaxation in of the intestine. The other modes are, it also acts by other voltage gated channels. It also controls anti-inflammatory process and also modulates psychological distress. Peppermint oil, multiple studies have been done on peppermint oil in IBS, and most of the studies have shown that there is significant benefit with use of peppermint oil. The usual recommended dose is 0.2 to 0.4 ml. Use it about 2 to 3 times in a day, and it has to be consumed in an enteric coated form. Otherwise, it is going to give you a lot of reflux symptoms. It can cause nausea, it can cause vomiting. There are some adverse effects like perineal burning. Rarely, some patient can also have nephritis. It is contraindicated in a patient with GRD or hyperthermia, and also in pregnancy because of the irritability nature. But apart from these things, it's an excellent product, and I have used it multiple times. And there is significant patient do get very significantly relieved from the pain symptoms. So next group of medicines are role of tricyclic antidepressants. As I discussed with you regarding gut-brain axis in my previous slides, there is one of the important aspects where these tricyclic antidepressants act, that is mainly in the brain as well as spinal cord. These TCAs help to regulate norepinephrine dopaminergic transmission at these levels, and they help to control visceral pain as well as central pain. And at a much higher doses, they can also decrease the intestinal motility, thereby thereby relieving the symptoms of diarrhea in a patient with IBS diarrheal type. Along with that, patients with TCAs also have an anticholinergic effects, which also helps to decrease intestinal motility. The main problem with TCA is that they frequently have side effects. Like main and common side effects are dry eyes, dry mouth. They can have dizziness, excess daytime sleepiness, and some patients also have cardiac arrhythmias also, and urinary retention. The most common TCAs which we use is amitriptyline, nortriptyline, imipramine, and desimipramine. We usually start at a very smaller dose of amitriptyline, that is 10 mg, and gradually you can increase the dose based on the response of the patient. But most patients usually require dose between 10 to 30 mg. With this dosage, most of them get symptomatic relief of pain, as well as most patients tend to have decrease in colonic transits, as so that they are relieved of symptoms of pain as well as diarrhea. Is there any role of antispasmodics to relieve pain? Yes, definitely. There are multiple antispasmodics which are available in market. Most common of them are the mebivarin, otilonium bromide, rotavirin, and hyoscine. So all these act by a common pathway, that is, they cause calcium channel blockade. They decrease the colonic transit and colonic transit time. Also, they cause direct smooth muscle relaxation. So the basic mechanism is that they relax the intestinal smooth muscles, they decrease the colonic transit time, thereby relieving the symptoms of pain. But these antispasmodic do not alter the course of the disease. That is, they do not have any role whenever it comes to the gut-brain axis. They just can be used for a symptomatic relief. and they are safe and they can be used on a long-term basis if the patient is having very severe symptoms. We commonly use it whenever while starting treatment for IBS, along with an tricyclic antidepressants, or it can also be used in a diarrheal form of IBS if the pain symptom is significant. So, what is the role of SSRI or and benzodiazepine? SSRIs are one of the important drug when it comes to functional bowel disease, and we commonly use them for treatment of functional bowel disorders. The main mechanism by which they act is they decrease the serotonin reuptake and promote serotonin activity. By this, they decrease the intestinal hypersensitivity and also decrease the colonic motility. SSRIs have a significant role to control pain, as well as they can also control the bowel motility, and they commonly we use them in patient with IBS with diarrheal form. But as you can see that there are multiple studies as well as meta-analysis which were done with SSRI in patient with IBS. However, the data is not sufficient to give a guidelines or a recommendation for use of SSRI. And the other problem with SSRI is that they have got significant adverse effects. Most common ones are anxiety, insomnia, headache, sexual disturbances, and some patients do also tend to have suicidal tendency. Uh, if uh, if this is being used in a patient with depression and IBS, then I would suggest you to use it very cautiously. Uh, the next one is benzodiazepine. As I told you, another target for is at GABA transmission neurotransmitters, which are mainly present in the thalamus and the brain. And by this, they regulate the pain transmission. These can be used only for a short-term benefit, wherein significant symptoms are very severe, and you start initially and gradually you can taper however, there is along as with SSRIs, benzodiazepines also do not have any recommendation from any guidelines as of now because the data is inadequate and multiple large center trials are needed to establish the role and recommendations for patients for benzodiazepines in IBS. So this was about the medicines which we commonly use in IBS. Next, we are going to discuss what are the newer medicines which are coming or which are already available in the market. One of such group is intestinal secretagogues. That is, there are two drugs or three drugs I can say. One is lubiprostone, other one is linaclotide, and the third one is plecanatide. These drugs mainly act on intestinal enterocyte and increase the intestinal fluid secretions. They also augment chloride as well as bicarbonate secretion, thereby accelerating the gastrointestinal transit. I'll just describe you the mechanism how these medicines work. This is the intestinal epithelial cells. This is the basolateral surface. This is the luminal side. Once the drug enters the epithelial cells, that is lubiprostone mainly acts on the chloride channel. It's a chloride channel inhibitor. Once the channel is inhibited, the chloride hormones out of this cell. Once the chloride ion moves into the lumen, there is more negative compartment which is established in the intestine. To compensate this negative ion, there has to be a movement of positive ion from the epithelial side into the lumen. And the positive ion is mainly a sodium ion. But you can see that instead of whenever lubiprostone acts on a chloride channel, instead of moving in sodium ion from the cell, the movement happens from the paracellular pathway. and the sodium ion moves into the lumen. Along with the sodium ion, there is a water content which also moves into the lumen. So thereby, uh, as the water moves into the lumen, there is more water available for stool to get softened, and there is also bicarbonate which ions which is also secreted along with this water as well as sodium, which helps to soften the stool and also increasing the colonic motility. The next is the linaclotide, which acts mainly on the guanyl cyclase. It's a guanyl cyclase agonist. Once the amount of guanyl cyclase is increased, it acts on the chloride channel at this end, and thereby increasing the transition of chloride ion from the cell into the lumen. And the same mechanism again happens there, as since there is negative uh, compartment in the lumen, there has to be a movement of positive ion from the paracellular pathway. And the net effect is that there is increased water content as well as increased
Hello, sir, are you there? Sir, have we lost the connection?
for a period of 3 weeks, but it can be used for a longer period of time as well. Linaclotide is another group which mainly, as I told you, it's a guanyl cyclase agonist, and the dose of which is 290 microgram. Both these drugs are recommended and they are FDA approved drugs, and they are usually recommended in constipation variant of IBS, and they give an excellent result. The one of the adverse reactions of these drugs is that mainly diarrhea. Apart from this, there are no significant adverse reactions. The next drug is allosetron. Allosetron is a 5-HT3 antagonist, and mainly it acts by decreasing the intestinal transit, and along with this, it also modulates the sensation and as well as motility. The usual recommended dose is 0.5 to 1 mg BD, and the recommendation mainly used in diarrheal form of IBS, but it has to be used with precaution as there is increased risk of ischemic colitis with in patients using allosetran. However, the incidence is about 1 in 1,000 population. Uh, the incidence of ischemic colitis is nearly about 1 in 1,000% population. Along with that, the other adverse reaction is constipation, and it is basically mainly recommended in women who have failed other forms of therapy, that is therapy from intestinal, uh, other forms of therapy like basic rifaximin or probiotics or other forms of therapy. Then such patients you can try and use allocetrans. Tegaserod, as you know, allosatron was a 5-HT3 antagonist, and tegaserod is a 5-HT4 agonist. It mainly initiates peristalsis reflex and accelerates GI transit. And its role is mainly in constipation type, and the usual dose is 6 milligram BD. It is also recommended in women less than 65 years of age and who have less than one cardiovascular risk factors and who have not responded to intestinal secretographs like linaclotide or lubiprostone. The main adverse reaction of this is diarrhea as well as cardiovascular events. The newer drug is uloxadoline. It is an opioid mu and kappa opioid agonist and delta opioid receptor antagonist. Its use is mainly in diarrheal form of IBS, and the recommended dose is 75 mg. The main mechanism by which it acts is it reduces the intestinal transit as well as decreasing the colonic sensitivity. There are few adverse reactions which can occur with uloxadine. The common ones are constipation and nausea. Rarely, it can cause sphincter of Odell dysfunction, thereby causing pancreatitis. Pancreatitis was mainly and commonly seen in group of patients where they had undergone cholecystectomy, or these patients, if they were on chronic alcohol dependence, then such patients tend to have increased risk of pancreatitis, and in such patients, this medicine has to be used cautiously. It is also contraindicated in patient with child cirrhosis or history of pancreatitis. So this was all about IBS and recent therapies or newer aspects in IBS. I'll just summarize whatever I have discussed in last 40-45 minutes. Basically, whenever patient comes with symptoms of IBS, you check whether he fits into Rome 4 criteria. If he fits into Rome 4 criteria, you rule out the red flags or alarm symptoms in them. Get a blood evaluation, blood as well as stool evaluation. If all these are normal, then you confirm the diagnosis of IBS. And also based on the sub classification of IBS, whether it's an IBS diarrheal form or it's an IBS constipatory form or it's a mixed form, you initiate the treatment. If it's a diarrheal form of IBS and if there is a recent history of bowel infection, then you can try rifaximin along with probiotic. If there is significant pain, you can use a tricyclic antidepressant or SSRI in such patients. If the patient has got constipation predominant symptoms, then you, along with dietary modification, you also initiate patient on isabgol. And along with that, you can, if the patient has significant pain, you can also start the patient on SSRI as well. Also use antispasmodic initial days, and then later on you can taper them. So once you have initiated the treatment, maintain the patient on those treatment for a period of 1 to 2 months. If the patient has feels significantly better or symptoms are under control, then you can gradually taper medicines one by one and stop it over a period of next 1 or 2 months. Why do we taper gradually is that, as I told you earlier, in pathophysiology, there is some gut-brain axis which has already lost its normal form, and there is neuronal plasticity. That is, even though there is absence of infection or any kind of inflammation in the intestine, the neurons keep on transmitting a painful impulse to the brain, and this cycles keeps on repeating. So in a patient with IBS, if you are going to taper medicines at the earliest, then the patient is definitely going to relapse in next few months. So you have to control the symptoms initially, then gradually taper the medicines one by one. If the patient is, the next set of patient is recurrent relapse or refractory disease patients. This patient, based on whether it's a diarrheal form or it's a constipatory form, you need to initiate the medicine, first line of medicines. If they are not responsive, then you initiate the second set of medicines. As in constipatory form, you can give lubiprostone or linaclotide. The main problem in our country is that these medicines are pretty costly, and affordability is a big problem. So at present, if at all, if it is necessary and if the patient is not responding to initial set of medicines, then you can start these medications. And once the patient is better, gradually you can taper and stop it. In case of IBS diarrheal form, you can use uh, alosetron or uloxodone, but uloxodone is still not available in India and it is yet to come to the market. Alosetron also is not available in market. One of the 5-HT antagonists which is available in market is ramosetron, which we use commonly, and the usual dose is 5 mg BD, which we treat, and it is useful mainly in diarrheal form of IBS. Once even that is the main basic thing remains the same. Once the patient is symptoms are controlled, then gradually you taper and stop all these medicines. There are some subset of patients, that is about maybe around 10 to 20% of patients, who do not respond to any of these medicines. Along with this, they have significant psychological illness like depression. They can have a psychotic problem. They can have a significant anxiety related problem. Such patient definitely need to undergo cognitive behavioral therapy, also evaluation by psychiatrists. And once their symptoms are controlled, they have to gradually medicines needs to be tapered. But this subset of patients need to be on medications for a long-term period. And once the psychological problem is also under control, then you can gradually taper and stop the medicines. So overall, if I have to summarize, IBS is a complex problem, and treatment it is also a complex problem, especially when it comes to a recurrent relapse or a refractory type of medicines, refractory type of disease. uh, a multidisciplinary team, or with the help of gastroenterologist, psychologist, as well as psychologist, psychiatrist, is necessary for treatment and management of IBS. With this, I conclude. If there are any questions, we can
Yeah.
answer.
Yeah, thank you very much, sir. Thanks a lot. We have few questions from the audience, so I can read out for that for you. So I got a question from Dr. Kalpana. So
Yes.
she wrote that after relief of 2 to 3 months with rifaximin course, how often are there relapses of IBS-D? How is that treated?
Yes. As I told you, we can use rifaximin initially in diarrheal form of IBS, and if the patient goes into remission, or if symptoms are controlled in a good way, then you gradually taper the other set of medicines. That other set of medicines could be an SSRI, it can be a tricyclic antidepressants. Gradually you stop them. How frequently these people relax? I'll tell you what the problem is. There are in our OPD, or anywhere in a gastroenterology clinic, there are large number of young patients who get diagnosed with IBS. Whenever you treat these young patients in a proper way and for a significant good amount of time, they go into a good remission, and the relapses are very less. The problem which we face is the elderly patient group, that is age group 50, 45 plus to 60-year age group. If these patients are diagnosed with IBS, then they tend to have frequent relapses. They are refractory and they are a bit difficult to control. Such patient, a proper counseling about the disease and multiple set of medicines will be effective, and they need to be under a good follow. That is what I can tell you.
Yeah, thank you so much, sir. Thank you for I mean to say answering the question, and I
Maybe I
say
think,
that, sir. Sir, could you
yeah, another question
unshare
is
the
by
slides?
Dr. Shamsundar Thorat. I think it is how long rifaximin can be continued.
Yes,
Rifaximin
yes.
usually the recommended uh, duration is just 2 weeks, and there is not much benefit beyond continuing beyond it, and there is not much benefit you if you're going to use it repeatedly as well. So just use it for 2 weeks and then stop it. Later on, you can use other set of medicines to control the disease.
Yeah.
I
Correct,
think
sir.
Dr. Kalpana
Correct,
has
yeah.
regarding allocetron.
Uh, eh,
I have not used, to be frank, I have not used allocetron, and it is not commonly available in our country.
correct.
As I
Correct, sir.
told you, ramacetron is available and it works well. And the usual dose which we use is 5 milligram BD, or if the patient is significantly better with the OD dose, even that would be fine. And use it for a period of about 1 to 2 months, and then gradually reduce it, and you can taper it and stop.
Yes, sir. So audience, do you have any question? You can post or you can unmute and ask to our speaker. Sir, could you unshare your screen? Yeah, so I
Yes.
can put you in spotlight. Yeah, right. Yeah, I got another question, I think so. Yes. Okay. By the way, Dr. Kalpana has thanked you, and she has posted yeah, she has posted excellent presentation, very informative too. Thank you, sir. Yeah. Any damage to
Any?
the any damage to the colons during therapy of
No,
rifaximin?
no. Actually, the rifaximin is a wonderful drug, and it helps. It for time being, it washes off the entire gut mucosa, and later on, it helps to regain the normal colonic or an intestinal gut microbiome. So that is how it works. It does not damage the colon or intestine.
Okay. So Dr. Shamsundar, thank you, sir. Thank you, Dr. Shamsundar, asking the question. Any questions, sir? I would like to know one thing, sir. You have discussed about that CBIT scores. So the patient you have to there are the lot of CBIT scores. So any
Yes.
handy CBIT scores you follow when the patients are coming, means you
Pardon?
suspect there are the multiple CBIT scores,
Yes, yes.
sure. So any handy CBIT scores you use for the when you suspect a
The
patient?
one
Yeah.
commonly which I use is IBS severity score,
Mhm.
and that is it works well and it classifies. There are nearly about 8 to 10 questions, and each question
Mhm.
has been assigned some amount of points,
Mhm.
and based on that points, it gives you a 50 score, 100, more than 150. And the more higher the score, the more severe is the disease.
Achha. Right. So IBS severity scores you follow for that, right, sir? Yeah. So any question, audience? Sir, how common is PI-IBS in your practice? That's called
Pardon?
post-infection IBS, PI-IBS.
Yes,
How
yes.
common?
It is significant. It contributes significantly. If I have to give you a number, prevalence-wise, there is no data available in India for this.
Mhm.
And if I give a vague number, then it could be about 1 in every 3 patients with IBS would have a post-infectious IBS.
Okay. So the symptoms are more severe in PI-IBS compared to the normal the
No, no,
patient.
the symptoms are not that severe.
Mhm.
Usually, such patients do respond to rifaximin as well as sometimes with probiotic as well.
Okay. Okay.
And the problem is that some patients tend to have relapses later on.
Okay. Okay.
Symptoms may not be severe, but relapses could be severe.
Okay. So Dr. Abhay Divakar, right? He said the great presentation. So you got a lot of compliment from the doctors.
Thank
It's
you,
a
thank
great,
you.
it's a very great, right? So any question? Yeah. Dr. Sam Sundar also said a nice flow of presentation. Sir, eager for more such patient session. Okay, sir, how do you decide when to use TCA and SSRI?
Yeah. The basic concept of functional bowel disease is that you check for whether the sleep is affected. If the sleep is affected, then most likely we are going to use a tricyclic antidepressant.
Okay.
And if the patient has a lot of globus symptoms, as I told you, if the patient has got a lot of aches and pains, there is a lot of headache, or some vague kind of problems they do. Sometimes even you get astonished to hear some patients describe to me that the gas is going to the brain and it is giving them nausea. Some
Yeah.
weird kind of experiences each parent patients have. So these are mainly the globus symptoms, and such symptoms need to be treated with TCI. And for TCI, there is significant data and there is recommendation that you can use it. And but one of the problem with that is it can cause constipation in some subset of patients. And usually with a dose of 10 to 20 mg, it is very well tolerated. So if the sleep is affected, we give tricyclic antidepressant. If the sleep is well maintained, then you can use a SSRI.
So we can, sir, I think so that we got a very good response from our audience. So we can close the session. So could we have that closing slide, please? Could I have the closing slide? Mr. Nandakumar, are you there?
Yes, I'm there. I'm just sharing my screen.
Yeah. So thank you so much that we are closing the session.
Thank you, everyone.
Yeah. So could you? Yeah. Thank you very much. Yes. So good evening all. On behalf of Jaidas, I, Chayan Majumdar, would like to thank Dr. Akshay Deshpande for his wonderful presentation. It was indeed our privilege to listen to you, sir, on recent updates in IBS management.
Thank you very much.
Last but not the least, my thanks to entire participating clinician, without whom the event would not have been possible. It goes without saying that we'll continue to rely on your affection and support now and hereafter. Thank you and good night.
Thank you, everyone.
Thank you so much, sir. Thank you so much. Thank you so much.
Thank you, Akshay Deshpande, sir.
Thank you.
Chanda.
Yeah, thank you. So I just close the meeting. I end meeting.